Hi, I'm here in Berlin at the second How to Diagnose and Treat Multiple Myeloma workshop for the European School of Haematology. Yesterday I was involved in a debate discussing the treatment of myeloma bone disease and whether treatment should be given continuously or personalised to specific patients. I was presenting data supporting the argument for continuous treatment for myeloma bone disease, and I talked particularly about two clinical studies, both of which randomised patients between two different treatments, but in both cases treatment was given until at least disease progression. So the first of these studies was the MRC Myeloma 9 study, where patients were randomised between the two bisphosphonates, zoledronic acid and clodronate. And the second is the denosumab study that's recently been published, which compared denosumab to zoledronic acid. In both of these trials, there was a progression-free survival benefit, and in the Myeloma 9 study, an overall survival benefit for one treatment over the other. And this suggests that potentially there is some anti-myeloma activity of these agents, as well as activity in preventing myeloma bone disease. So the arguments that I presented yesterday were that in these studies, treatment was given to disease progression and not stopped after a limited duration of treatment, and that therefore, if we hope to replicate some of the findings from these studies in our clinical practice, that is the way to go. The counter-argument to that was presented after my discussion was that obviously we need to be careful when thinking about the toxicity of some of these agents and consider that when we're thinking about the duration of therapy for each individual patient and personalise their therapy potentially based on that. And also there is some data from the Myeloma 9 study suggesting that patients who achieved a deeper response didn't see as much benefit from the zoledronic acid over the clodronate, and that therefore that might play into thinking about how long patients should receive therapy if they've achieved a deep response to their induction treatment for myeloma. So the audience conclusion at the end of the debate was that we should personalise therapy and consider all of these things when we're making decisions about myeloma bone-directed therapy for our patients.